Hello and welcome to the COMLEX Instant Review. Please visit www.comlexflashcards.com for complete COMLEX prep resources. Today's topic is metabolic acidosis. Keep in mind, in metabolic acidosis, the bicarb is always less than 24. First step you want to make sure you do is you calculate the anion gap. That's the sodium minus the sum of the chloride and the bicarb. So the normal anion gap is usually between 8 to 12. Let's take a look at this algorithm here. Patients who have metabolic acidosis can have a high anion gap or a normal anion gap. For patients who have a high anion gap, you first look at whether or not there's serum ketones present. If there is, then you're looking at ketoacidosis. If the lactate is elevated, then you're looking at lactic acidosis. If none of these are elevated, then you're thinking about aspirin, methanol, ethanol, or ethylene glycol in your differential. For normal anion gap, you want to measure the urine anion gap next. If it's positive, you look at the impairment of renal and acid excretion, and if it's negative, then you're thinking about GI losses. And so understand that these first two steps here are very important before you come to the conclusion here. And immediately in your lab studies, you should order ketones and lactate. The differential diagnosis for metabolic acidosis can be easily remembered by knowing this mnemonic mud piles. Here you have methanol, uremia, diabetic ketoacidosis, paraaldehyde, INH, lactic acidosis, ethylene glycol, and salicylates as some of the causes of anion gap metabolic acidosis. Also, these are some of the other causes: lactic acidosis, ketoacidosis, renal failure, and toxins that you should always keep in mind. And here's how you can differentiate each of these. You can look at the toxins, you can look at renal failure, you can look at ketoacidosis, or you can look at lactic acidosis based on INH therapy. Again, if none of those are true, then you can look at the ethylene glycol poisoning, which would have a high osmolar gap. So, in review, anion gap is very important to calculate because it's going to help you understand your differential, whether patients have methanol ingestion, uremia, diabetic ketoacidosis, INH, lactic acidosis, ethylene glycol ingestion, which may show urinary calcium oxalate crystals, as well as salicylate ingestion. And so what happens here is that the treatment is mainly to make sure that you correct the underlying cause. If there's a normal anion gap and patient has diarrhea, you're thinking about other causes like GI fistulas, any sort of urethral diversions, excessive IV normal saline, or TPN, renal tubular acidosis. And so if it's normal anion gap, you have a different differential and you want to correct that. Now, keep in mind several changes in non-anion gap is that there's a decrease in bicarbonate and an increase in chloride, and so it's called a hyperchloremic acidosis. You want to understand if it's a renal versus GI loss of bicarb, and the treatment would mainly be bicarbonate therapy. So once you calculate the anion gap, if it's not elevated, then you're looking at the treatment here, which is pretty much the same, and that includes bicarbonate therapy. Again, here is our chart which can help you understand the differential. And in normal anion gap, you're looking at GI losses as well as impairment of renal acid excretion. So the non-anion gap metabolic acidosis has a mnemonic as well, and it's called used car. The U stands for urethrosigmoid diversions, S is for saline administration, E is for ethanol, and D is for diarrhea, and C is for carbonic anhydride inhibitors, hyperalimentation, and renal tubular acidosis. These are some common scenarios you may see on the boards. For example, accumulation of urine in the colon, causing reabsorption of chloride and water by intestine, leading to secretion of bicarb into the intestine. And so also, addison, spironolactone, all these endocrinopathies can cause a non-anion gap metabolic acidosis. And so here's our chart, which you want to keep in your mind. And so understand that here is the formula in order to calculate the urine anion gap, and that's an important step for diagnosing patients after you see that there's a normal anion gap acidosis. If it's normal, it's either 0 or positive. If there's metabolic acidosis, the NH4 excretion increases, which is excreted with chloride if the renal acidification is intact. Okay, so that's an important point you want to keep in mind. And there's also GI causes that you want to look into, as we had mentioned in our algorithm. And this may be due to impaired renal excretion, like an RTA. And here you're going to find a positive or 0 urine anion gap. And there's different types of RTA. There's type 1, which is distal, and there's inability to secrete hydrogen ions into the urine distal tubule. And the pH is usually very high here, greater than 5.5, and it's hypochloremic state. Commonly seen with nephrocalcinosis, sickle cell disease, or multiple myeloma. And then there is type 2, which is more proximal, and here patients have hypokalemia, usually associated with Fanconi syndrome, and it's mainly an inability to absorb bicarb. There's also type 4, where you have a hyporenemic hypoaldosteronism, where the urine pH is less than 5.5, and patients have hyperkalemia. And so it's important to know these facts as you're looking to your answer on the board question. Again, remember the mnemonic used car, calculating the urine anion gap here to help you determine whether if it's due to a impairment of renal acid excretion or due to a GI loss. So let's recap everything and look at this algorithm here. Okay, if you have an increased anion gap, you're looking at, first thing is whether there's ketosis. If there's ketosis, then you're going to be looking at causes of DKA and so on. And if you want to go further, you can order an ammonia level to make your differential even more specific. Okay, and if you're looking at an increased anion gap, then patients who have no ketosis, you're going to order the lactate levels. And if it's a high lactate, then you're going to look at lactic acidosis on your differential. But if it's a normal lactate and a normal sugar, you're looking at other causes as seen in this algorithm. So this is a nice figure to keep in mind as you're preparing for the board exam. Keep in mind, the main step you want to understand is you want to know if the patient has a high anion gap or a low anion gap. If they have a high anion gap, then the first thing you want to do is order some lab tests. Order some lactate, make sure the patient doesn't have any ketosis, and then look at your mud pulse differential. If it's normal anion gap, then you look at the used car differential or the urine anion gap, and take your differential whether it's GI losses or non-GI related. So that's a recap of metabolic acidosis. You can find lots more information on COMLEXflashcards.com. There's a daily blog that you should subscribe to as you're preparing for board exams and throughout medical school. It's totally free, and good luck in your preparation for the COMLEX board exam.